Hi, everybody. Welcome to Be Time. I'm Beth Bierbauer, healthcare executive, author, and host of this podcast. Be Time is designed for individuals who want to invest in themselves and their careers through continuous learning. Each week, you have the opportunity to broaden your horizons as I interview top executives and other seasoned individuals from the healthcare industry and outside of the industry. So whether you're with a large corporation, a small business, or a startup, whether you're in or outside the industry, Be Time has something for you to help you stay on top of your game. Now, before we get started, I have an ask. Please go onto your favorite podcast platform and give us a 5-star review. It helps others discover good content and helps boost our ratings as well. We appreciate it. So let's get started. We all know there are problems with the healthcare ecosystem. Everybody operates in silos. And over the last 100 years or so, we've been really focused on improving physical health. And that has resulted in specialties and subspecialties being formed, and physical health has certainly improved, but costs have continued to rise, and many other issues are not addressed for the patient. Now, over the last decade or two, there has been an increased focus and awareness around behavioral health, and the funding for behavioral health has significantly increased as well. We've seen some introduction of some new services, such as the text crisis hotline, and we know that there will be a new national suicide prevention hotline coming out in the next year or so. Again, these are significant improvements, but costs for healthcare continue to climb. Now, in recent years, health plans in particular have really begun to focus on what they refer to as social determinants of health. They believe if they can address the issues around food insecurity, lack of housing, and transportation, that they can help people eliminate the barriers and obstacles that prevent them from getting the health care that they need. And again, some progress is starting to be made here, but costs continue to climb. There is a belief with some compelling numbers behind it that if you can really integrate these different silos and really look at the patient from a holistic perspective, you can improve outcomes and lower costs and effectively manage care. That makes sense. It's really difficult to engage someone in their care if they don't know where they're going to sleep that night, or to help somebody improve their health care when they have to choose between putting food on the table or buying a prescription drug. Food on the table is going to win out every time. The good news is this: there are many places in the United States where really smart people are tackling these issues. They are creating integrated models of care, and that's exactly what's happening with Cityblock Health. They are a New York-based organization that was developed out of Alphabet's Sidewalk Labs, and they work with providers, health plans, people on Medicaid, and low-income Medicare Advantage individuals to ensure that these individuals have access to high-quality, high-value care in a personalized way that's going to meet their needs. Cityblock Health applies leading-edge care model delivery as well as technology to bring together primary care, behavioral health, and social services. And they help empower their individuals to improve their health. With me today is Dr. Toyin Ajayi, who's co-founder and chief health officer of Cityblock Health. Dr. Ajayi was formerly with Commonwealth Care Alliance, as was her co-founder, Aya Ram. And we're going to ask Toyin today to explain to us what she learned at Commonwealth Care Alliance, what she was thinking about changing when they decided to incubate out of Sidewalk Labs, and what it is that Cityblock Health is doing today to improve the health, physical, emotional, and social of its members. So please join me in welcoming Dr. Toyin Ajayi to Be Time. Toyin, welcome to Be Time.
Thank you. It's really, really great to be here.
Toyin, let's begin by sharing your background. You've lived in a variety of countries. You've obviously seen a variety of healthcare issues and healthcare systems. But why don't you talk a little bit about your background for our audience?
Sure. So I was born here in the U.S. in Boston at Boston City Hospital. At the time, the sort of local safety net hospital, and ironically, where I came back to train many years later. and then grew up in Kenya. And so I grew up in Nairobi, capital city of Kenya, really sort of bustling metropolis. Healthcare there is entirely fee-for-service, like totally stratified based on ability to pay. And so I saw a lot of real disparities in terms of health outcomes and experiences for people who were less fortunate than I was to grow up with the resources that I did and the family that I did. I then moved back to the US for college and spent 5 years in the Bay Area college and then worked for a year afterwards in San Francisco. And so had the experience of being a student, of accessing the healthcare system from that lens, and also of being a pre-med student. And so learning about the US healthcare system there. I left the US for 5 years or so, went to the UK and spent a year at Cambridge doing a master's degree and then med school in London. And so got a lot of my formative kind of clinical training in a system that believes and supports healthcare as a universal right, and that has a really interesting kind of capitated approach to community-oriented primary care in particular, and got to see a system that really thought about kind of spend for healthcare really differently. And then came back to the US and ended up in Boston for almost a decade, actually, where I did my postgraduate medical training and had a little foray in between, actually, of about a year and a half or so in Sierra Leone, working in the capital city in Freetown, supporting kind of community health, particularly focused on people who were urban populations living in slum areas. And went back and forth between there and Boston for many years before ending up in New York. So that's the circle.
That's extremely fascinating. Extremely fascinating. Now, what inspires you to become a doctor? Was there a specific incident or just your general experiences as you just described?
I was always very passionate about healthcare and about really thinking about social justice. Before I had language for it, I was very conscious of my privilege as the daughter of two master's educated parents who, my dad was a doctor, is a doctor, spent his career in global public health. We had really active conversations at the dinner table about the fact that, despite the fact that we were growing up, my sisters and I, in a household where we had 3 and more square meals a day, a roof over our heads, access to incredible education, it was sort of a given that we would go forward with our education and really be able to contribute to society. We also were very, very conscious of the fact that there were lots of children around us in our community who looked just like me, but had very different outcomes and opportunities, and particularly was very sensitized to reproductive rights, to healthcare and health outcomes for young women, and young Black women, young African women in particular. We grew up at the time of the ravages of the HIV/AIDS epidemic in sub-Saharan Africa, at a time when the life expectancy for most adults was in the 30s because of that pandemic, and that epidemic. And so I always knew I wanted to help people and heal people in some way. I did not think I wanted to be a doctor necessarily, because I was very interested in systems and have always been very interested in systems and trying to have sort of maximal impact for the maximal number of people. And being a doctor seemed in some ways too focused on one individual, and too therefore limiting in terms of its potential long-term scope. But I was convinced to go to medical school by my mentors, who I think at the time were trying to be pragmatic, but also kind, who suggested that as a woman, particularly as a young woman and a young Black woman who wanted to have real impact in the world, that having more degrees was always helpful. And if you're smart enough to go to medical school, you should get that degree because people will listen to you. And so I actually went to medical school initially because I thought I needed the leverage, and did not think I was going to practice, and surprised myself and many others by falling in love with just the quiet simplicity of being with a person who is sick and suffering, and the ability to bring knowledge and empathy and compassion and communication skills to help them sort of navigate that time. And I fell in love with primary care. And it is interesting to me, and no source of joy, that continuing to see patients is one of the kind of highlights of my career today. I continue to just derive so much joy and energy from it, and have been really fortunate to find a way to bridge clinical practice, that day-to-day impact you can have on an individual human and their family and their life, with a systems approach, and being able to do work that really does have the potential to impact hundreds of thousands and millions of people at scale over time, which is what I always wanted to be able to do.
So public policy was discussed around your dinner table. How about your
All the
siblings?
time.
Did they
All
get
the
into
time.
public policy as well, or healthcare? Or?
In their own ways. So I have two younger sisters. One of them is an economist, and she works at the World Bank. She spent many years in academia as a professor, and now works specifically on gender and women's opportunity in the labor market. And so that's her piece and her contribution. My other sister's a management consultant who's really passionate about leadership, and specifically works with companies to try to help them listen to and enhance their ability to be productive through relationships. And that's been her approach to sort of social justice, if you will.
Oh, that's fantastic. And kudos to your mentors. They gave you really good guidance. I think that you would agree that having that additional training probably has proved extremely beneficial.
Yeah, it has. It has. I was resentful at the moment because one likes to start their career thinking that there's a level playing field, and it was very apparent to me that there was not necessarily. But it was really good advice, and it helped me find a passion that I wouldn't have found otherwise.
Well, let's start a little bit with Commonwealth Care Alliance, where you and your co-founder both worked. What were you trying to accomplish at Commonwealth Care Alliance, and then we'll move it forward from there.
Sure. So I started at Commonwealth Care Alliance very early in my career. I was just a couple years out of residency. I'd been working as a doctor in the hospitalist service at Boston Medical Center, which is where I trained, and was starting to cultivate, I think, very early ideas or perspective on why our healthcare system was failing so many of the marginalized populations that I was really passionate about serving. I was really, really interested in taking care of people who struggled with clinical and social and behavioral health needs that the traditional healthcare system was just not equipped to manage. This was sort of before we had like widespread socialized language around high cost, high need patients, or, emergency room frequent flyers. We didn't have real like a way to describe the populations I was talking about. But for me, they were the folks that, my colleagues in primary care, your heart would sink when you saw their name on your list of patients for the day, because either they would show up and they would have so many things going on, you'd feel totally inadequate to solve them, or they would have so many things going on, you would try to solve those issues and you'd run behind and your whole day was kind of totally screwed up from a schedule perspective, or worse still, they wouldn't show up at all because they were in the emergency room or they hadn't followed up with the appointment, and you'd leave the day just feeling like there's so much more you could do. And from the patient perspective, these were the folks I was seeing on the hospital side, showing up with, disseminated cancer that was diagnosable and preventable and treatable, with recurrent hospitalizations for things that we should know how to take care of in the community setting: diabetes, high blood pressure, strokes as a consequence of unmanaged, poorly managed chronic physical health conditions. These were people who would end up in restraints because of serious mental illness. And it just was so bothersome to me that we were not making a dent on these individual patients' lives. Started to get pretty agitated, I think, and was really trying to figure out how to practice in a way that was aligned with my values and my sense of what my job should be as a doctor who was passionate about systems change. And it was not taking care of patients only to see them come right back in worse circumstances over and over and over again, until I ultimately had to tell them that they had a terminal condition. Like, that was not feeling aligned for me. And I was approached by Bob Master, who is the founder of Commonwealth Care Alliance. He's a self-described kind of rebel doctor who himself, I think, had gone through a similar period earlier in his career of just really trying to figure out what his place was, and asked to join this team of really passionate clinicians and clinical operators who had built a health plan around serving people who were dually eligible for Medicare and Medicaid, and who had done so from the lens of being a provider organization that really wanted to figure out how to align all of the resources as best they could to ensure maximal outcomes, and get away from this sort of fee-for-service, just sort of rigmarole that we're in, this cycle of doing more things to people that weren't actually changing their outcomes. And so I basically joined the team almost sort of without real context. I barely had a job description, I think, because it was my people. The promise was that I would get to take care of my people, my patients, the communities that I really loved and was passionate about, people who struggled with mental health and substance use challenges, people who'd lived a life of trauma, people who had just from the very beginning not had access to basic services that they needed to thrive, and that we could do so in a way that allowed us to really intervene as far upstream as possible with as many tools as possible in a business model that was going to hopefully prove to be scalable. And so I joined right before Commonwealth Care Alliance entered the dual demonstration, the dual eligible demonstration in Massachusetts, and took on the care of and the economics around the care for tens of thousands of people under the age of 65 who are dually eligible for Medicare and Medicaid. And I got to build clinical programs. I got to build teams, build strategies to improve outcomes, to align around that, ever elusive triple aim of decreasing spend, improving quality, improving satisfaction and engagement, and got to prove that it was possible to do that. I got to go back to being a primary care doctor, taking care of women who had, older women over the age of 65 who had had struggles with housing, many of whom had substance use issues or mental health challenges, all of whom had had some trauma within and around the healthcare system. I got to do home visits and see people in shelters and in community gardens and really come back into harmony with the things that had driven me to become a doctor in the first place, and to do so while building systems that were also oriented around better outcomes. So that was the vision for us.
Well, extremely inspiring. And I too actually got my start from a primary care foundation. I started with a staff model, HMO. Nice. So once you, I think, had that view that, starting with primary care, really focusing on the person, really taking care of them, not doing the traditional fee-for-service system, if you will. It's just a different view. And I think once you get embedded in that, I've just never been able to shake it. It just feels like the right approach to me. And of course, as we progress over the years, the healthcare system is trying to move that way, not anywhere near where it needs to be. But It really, when you're fortunate enough to have a primary care physician and to be in a model or care delivery system that really looks at somebody holistically, it just makes a world of difference.
It totally does. And it reminds us, this is almost part of the core thesis around Cityblock, that there actually are so many opportunities to fully align the economics of healthcare with what patients need and want, and that it's possible to do that, and it's possible to do it at scale, that those two things do not need to be in tension. We should not be sacrificing patient and community outcomes for the bottom line. It is possible to be successful in healthcare without ever having to do that. And in fact, by harnessing the economics to better improve outcomes, we really are able to create something scalable. And that, I think, once you see that, just taking better care of patients and doing it in the ways and the spaces that they want and need, actually is sound business practice. Like, once you see that and feel it, to your point, you can't shake it.
So from Commonwealth Care Alliance, you moved to Sidewalk Labs, which is a part of Alphabet. Were you going to start a new model from scratch? Were you going to improve upon some of the things that you just felt, didn't happen quite the way they should have at Commonwealth Care Alliance? What was your thought behind that work at Sidewalk Labs?
Yeah. So, over the years that I am my co-founder and Cityblock CEO, and I had been working together and forging a friendship that was really, born out of this alignment of sort of overall personal mission, which is really about transforming the healthcare system for people who need it to be different, for people who need it the most, and doing so at scale. I think we both had a real appetite for making models like the model at Commonwealth Care Alliance the norm as opposed to a small exception. We had been talking about what it would look like to do that. What are the necessary ingredients to radically transforming that experience of care for most people who need it to be different, most people who are struggling with complex needs, who are covered by Medicare or by Medicaid or both. How do we make this like at scale really different for them? And we knew that we needed a few ingredients that that would take capital and would take time and space to build. We needed a care model, obviously, and that was a piece that I'd really learned and gotten to prove and test out the value of an interdisciplinary care team, the value of outreach and engagement, meeting people where they are, the value of bringing physical health and behavioral health and social care all together in the same spot. The value of being really driven to the members' needs in terms of where they want to access care, not being constrained by physical space or by, the hours of 8 to 5, but really being multi-channel, available to people in their homes, in their community gardens, in the clinic, if need be, virtually. So we had that piece, and we understood it and really understood what it looked like to operate that at scale. We needed technology. We knew that the way that health tech had been oriented had largely left behind marginalized populations. They'd left behind the needs of communities like the communities we were seeking to serve. The need for data, for analytics, for decision support, for business process, for operational tools and workflow tools that support the type of communication that we were pushing forward was so critical. And we didn't see it out there in the market. And then we knew we needed a really, really different approach to making the business case at scale. We needed a chassis around value-based care that was oriented towards primary care and behavioral health and social care, that funded upfront the types of clinical interventions that our populations needed, but also was accountable to real world economics such that we could grow and scale. And Sidewalk Labs sort of gave us the opportunity to take a minute and to sit and build out a strategy, build a business case, meet our collaborators and co-founders who came from the Google family and really brought that technical capability set and that product capability set, and then start to find our first partner and launch our model from there.
That's pretty amazing, where you're able to bring your expertise, the expertise of your co-founder, and then marry that with people with deep technological expertise to really be able to change the game. So let's launch into Cityblock. Tell our audience, exactly what it is, what's your mission, why is it unique?
Yeah, so our mission is to radically transform care for marginalized communities at scale. And what we do is we partner with health plans and at-risk providers in a value-based arrangement that allows us to deliver primary care, behavioral health, and social care to folks in largely urban areas that have been underserved, with the intent of improving their outcomes, their quality of care, their experience and engagement, and decreasing avoidable spend in the healthcare system. So that's us.
You said two things that oftentimes people don't get, but you talked about serving a population in an urban area that's underserved. And if you look at healthcare, just typically from a geo-access perspective, most people would say, well, how can you be underserved in an urban area? There's a density of providers. Yet that is the case in most urban areas, that there is a vulnerable population that simply just does not get the services that they need. And that's what you're there to do.
Absolutely. And I think it cuts in so many different ways, and you can see it in the data, and you can certainly hear it in people's experiences. And it was something that was very salient to me very early in my training in Boston. Boston is sort of, in many people's eyes, the sort of mecca of advanced medical care. I mean, I used to joke, it's like you can't, stop at a street corner without tripping over some cardiologist or radiologist or some other clinician. These massive, massive institutions of clinical excellence. And yet I was seeing patients in my community health center practice who hadn't seen a doctor in 30 years. Who were showing up in distress in the emergency room with advanced cancers or chronic conditions, not because they didn't have insurance. It was a state that actually very early had really striven to create almost universal insurance coverage, not because there weren't hospitals or clinics But because we were doing something in the way that we were seeking to engage communities that was not reinforcing of trust, and that was not creating real access to services. And it's really interesting that I had seen the same thing in Sierra Leone when I worked there, where we were working in a safety net hospital, a government-run pediatric hospital, right in the middle of a slum area that is actually in very close proximity. It's a very densely populated country, very close proximity to probably about 1 million people could access this institution. It was free. But we were seeing families bring their kids in, at very late stages of distress, kids who had fever for 7, 8 days, who'd been losing weight for weeks and months. And when we started to actually survey patients and their families, what they told us was that they didn't trust this place, that they had other choices, and they sought to use those choices. And it may be, community healers, it may be just hoping and praying that things got better. And the same is true for individuals living in urban centers in the United States, where there may be doctors, there may be clinics, there may be hospitals, but if they're open only between the hours of 8 to 5, and you have to make an appointment 6 weeks in advance, and if you don't reconfirm it, within an hour before you get there, you may not have a space. And when you get there, you have to wait a really long time, and people lecture you for things, and you have to find childcare and transportation. And guess what? You're trying to figure out how to feed your kids and keep the lights on and keep a roof over your head, and actually that diabetes that doesn't bother you on a day-to-day basis may not be the number one thing on your list. And getting lectured about it by somebody who doesn't know anything about your life is not actually going to change your behavior. We've got to really rethink the way that we deliver health if our goal is to deliver health as opposed to healthcare, because in those same infrastructures, we can grow very successful healthcare businesses on the basis of doing exactly that same sort of delivery model, where if you come in, you get seen, and you get the time that you get with a doctor, and you get a prescription, and you get, a little counseling. And if you follow the prescription through and actually take the meds, or you don't, so much the difference. And actually in many instances, if you, the patient, don't follow through, take the meds, and get better, we blame you. We call you non-compliant. We say you are a bad patient. Sometimes we fire you from the practice if you don't show up multiple times in a row because you're wasting our time. And that is all the hallmark of a healthcare system that is focused on itself and focused on the delivery of services, and not focused on health and on the outcomes of the population. And that is exactly the incentive structure that we're seeking to upend. That I think that, we're not visionaries, or we're not unique in this instance at all. There's a movement in this country towards value-based care for exactly that reason, because we have to start to align the people who deliver healthcare, people like me, around the fact that my job is not done, and I should not get to call myself successful until I can prove that I'm actually delivering better outcomes to the people I'm supposed to be serving. And that is a really, really radically different approach to the role of healthcare providers and healthcare institutions, ironically, created by the business structure around it.
So you talked about trust, and so I have a question that a lot of health plans, a lot of people are focusing on social determinants, which I agree, very, very important. But I wonder if they don't get that develop that trust, adding that additional layer still isn't going to get it, is it?
I think that's right. I think that when we talk about social determinants in healthcare, and it is very much a sort of buzz phrase these days. What we're really talking about, and I think we have to be really clear about it, is we're talking about treating the symptoms of a broken healthcare and social infrastructure. And we're talking about feeding people who have chronic conditions, who are hungry and malnourished. We're talking about advocating and providing support to people who have medical or mental health needs, who are homeless. We're talking about treating symptoms that eventually will result in hospitalizations and morbidity and mortality. And in order to do that, we have to understand what those symptoms actually are for people. And we have to do that in the context of a trusted relationship, because why in the world would somebody tell you that they're hungry, or that they can't read the instructions you've been giving to them for the last few years, or that they cannot afford their medications, unless they trust that you will use that information to help improve their outcomes, and that you will use the relationship that you've built with them in order to help do things with them and for them that are in their best interests.
I think that's really important, especially for our audiences as we think about executives that are in these positions of developing programs and processes. It isn't going to be about check the box, oh, we have this program. Really going to have to figure out how people in your organization, whether you're a provider organization, a health plan, how they can begin to really develop trust with their members or their patients, so their patients can then open up and say, hey, listen, here's what's really going on. So I think that's really, really important, and probably not something that a lot of people have really put a lot of thought into. As to your point, they're going down the path of, oh, well, we'll just make sure that we can refer to the housing authority when somebody's homeless or something. You're really going to have to think about developing a trusted relationship, which leads me to your community health workers. You do something really unique in that aspect. Why don't you tell us about that?
Yeah, I mean, we firmly believe that that trusted relationship is a critical requirement for engagement and for long-term better outcomes. And actually, I believed it so much that way back when I was working as a hospitalist, I used to have these 2 questions that I would ask every patient that was new to me, that I admitted to the hospital. And I always wanted to do a study on it and never did. But the 2 questions were, do you have any human, like one person who's connected to a healthcare institution who you know and trust? And when I mean that, what I mean by that is, if they saw you on the street and on a random Tuesday, they would know you by name and you would know them by name, and they know something about you that is personal about your life. Do you have a person in healthcare? And the second question was, do you have a person in your personal life? Do you have a loved one, a friend, a family member, a partner, a child who you could trust to make decisions on your behalf if you were unable to do so? You have that level of trust in them. And my hypothesis was that independent of what your disease state was, what your clinical condition was, if you said no to both of those questions, you are at significantly elevated risk for a rehospitalization, for a poor outcome, for long-term bad outcomes, because that trusted relationship in healthcare is incredibly rare. Very few patients actually said yes. Very rare. You may have a PCP of note on paper. You may be in the hospital once a month because your asthma flared up, but like, is there a human who you know knows you and who you trust in the healthcare system? Like, very few patients, when I was seeing people in the hospital, would say yes to that. And I believe that is a necessary precondition for long-term better outcomes. I don't believe it's possible to really understand what's going on with a person, to be able to work with them, to collaborate around driving interventions that have impact for their health and well-being, helping them achieve their personal goals, unless you have a trusted relationship. I also believe that the doctors and nurses, I know the doctors and nurses and social workers are not always trained to, nor are they best positioned to hold those relationships, because we come with baggage too. We come with the historical baggage of our profession that has often treated marginalized populations and individuals without trust, without respect, that often reverts to hierarchy, to telling people what to do, to doing things to them and at them as opposed to with them, and that creates cultural and linguistic and other barriers to that true trusted relationship. And so we have really built our model around the notion that that we need to hire and train and equip people who can build those relationships and hold those relationships and use them as a way to really meet people where they are at and to solve the needs that they identify together, to solve what matters to the member. And that to do that, we needed to really orient around a different workforce. And those for us are our community health partners. These are folks we hire from the communities we serve. We hire them for skills around empathy, active listening, relationship building, tenacity, follow through. They're experts in social care and they're experts in relationships. And we value that. And we value that contribution to the team. We center them and orient around them with with an interdisciplinary clinical team. So they have that collaboration and that support of clinicians on their team as well. But they really hold that relationship with our members, and they become that bridge to the healthcare system in a way that really allows us to drive meaningful engagement and impact over time.
You know, I know what I think I know what I'm doing in the healthcare system because I've been in it so long, but I want one of those. I mean, that's fantastic, right? To know that
I know, kind of everybody should have one, right?
That's amazing. Most people need this because, you know, right now you pick up the phone, you have a question, you know, you get an 800 number if you're calling your health plan, and you talk to one of 1,000 different people, never the same person. Even in your provider's office, you know, you may talk to this one, you may talk to that one, and you just really need somebody that can sometimes help guide you and maybe help hear what you didn't hear, even though something was said, right?
That's right.
So that's really fantastic, especially when you're talking about the vulnerable population. Now, your model is heavily face-to-face, but here we sit in the midst of COVID. How did you pivot? What did you have to do differently?
Yeah, COVID, goodness. So it allowed us to, and it really forced us to accelerate some of the work that we had already been doing in learning how to digitally engage communities who may not have a ton of access to technology, to data, to the App Store and places where people traditionally deployed digital tools. But you know, our priority going into COVID was twofold. One was to make sure that we were keeping our care team members and our members clinically safe, and that meant really adhering to and abiding by guidelines and recommendations around social distancing. And it was also to make sure that we were absolutely not stepping back from our commitment to showing up for our members when they needed us, and to providing them with a level of care that they needed to stay healthy and well. And that included preventive care as well. And so it was not an option to us to completely close down our clinical in-person services. In fact, we had to intensify and amplify our ability to see people safely in their homes for clinical needs in person when it required us to do so. And also, there was an imperative for us to start to deploy technology really differently and to accelerate that roadmap. And so we pivoted quickly, like many provider organizations did, to virtual visiting, to video, telephone, SMS, a combination of all three. We learned a lot about how to facilitate tech access for our members, and how to troubleshoot and help support people in accessing technology. We trained our clinicians and our non-clinicians on our team to really be able to use that technology to build and sustain relationships and to troubleshoot with our members. And we also continue to provide in-person services in people's homes where necessary, because it was so important to us to make sure we continue to meet people's needs.
Oh, that's certainly amazing. Can you share with our audience, are you starting to see some outcomes from your model?
We are, yes. So we've been operating in our biggest market, in our first market, since the summer of 2018. And we are seeing that in the members that we serve, that we're engaging people, often people who had not had meaningful engagement with the healthcare system, and prior to that, at least with the kind of community-based primary care and care coordination infrastructure. They maybe have been using the hospital a lot, but we're not really engaged in preventive care. We're seeing that we're engaging them at significant rates, much higher than typical health plan care management entities or typical provider organizations. We're seeing that hospitalizations, particularly due to ambulatory care sensitive conditions, to things that we can avoid through better community-based care delivery modalities, are reducing those populations, while satisfaction and engagement and that experience for members is improving. So yeah, we're starting to see outcomes, and we're excited to see that.
Well, that's fantastic. Now, you mentioned earlier that one of the reasons that you went to work with Sidewalk Labs was because you could partner with people who had deep technological expertise. What I find interesting is many startups are saying, we are building this from scratch. Why is that? What are the gaps in the existing technology that folks like you say, this isn't just going to cut it. I'm going to have to really do something very different here and invest in that technology?
Yeah. So I think the first big gap that was really obvious and very compelling to us was around data and analytics. And so, predictive modeling, the ability to identify across a population who is most at risk for a bad outcome, for a hospitalization, for something that will meaningfully impact their life, and what is it that's impactable? What are the things that we could actually intervene on and expect to see different outcomes? The tools out there typically focus on a healthier population, folks who don't necessarily have social needs as major drivers. And so the example that I would give as an anecdote, but that actually I want to see us like codifying data is, we all know that somebody who say has, chronic kidney disease and has to go to dialysis 3 times a week, and maybe has diabetes and high blood pressure, and at some point in their life had a stroke, that seems like a high risk person. What we don't see reflected in data and in the data tools that were out there is that if that person lives with their partner of 30 years, or their daughter lives downstairs, or they've had a longitudinal trusted relationship with a primary care doctor who they, see and communicate with once every 3 months. They read English as their first language. They have access to transportation. They have a retirement or some other income, so they have enough food on the table. That person is a very different risk profile than exactly the same clinical diagnoses and the same sort of medical diagnoses in a person who, for example, maybe has had 5 different addresses in the last 6 months because they're couch surfing, who recently got laid off from their job, whose pet cat that they loved has just passed away, who experienced a horrible traumatic experience in their childhood and has trouble sleeping and sometimes takes medications or illicit substances to help them with their anxiety and their depression. Like, that person is fundamentally at much, much, much increased risk. And yet most of the data tools that were built around risk stratification and modeling are totally blind to the nuance of that social circumstance I just described to you. And understanding where social context is both protective and can also be a risk factor. How do you nuance that? Then saying, okay, so we need to understand the data in a much more holistic way, and we need to privilege and value the social data and the behavioral health data as much as we do the claims-based clinical information and the diagnoses, because what makes us human and what makes us makes up our experience as humans is not just like, what's my kidney function, what's my heart function. It's how do I as a human interact with other humans in my ecosystem, and what are the beliefs and practices that I bring around that, and what are the support structures around me, and like, how do we actually turn that into actionable data? How do we gather that data, normalize it, and learn from it, and start to use that as a way to predict and impact? The next piece is then, how do we build decision support based on those insights that is tailored to our populations? And one of the things that used to frustrate me all the time as a clinician in the hospital in particular was seeing patients. I have this like classic example of a gentleman who was in and out of the hospital, I would say probably every week or 2, who was struggling with alcohol use abuse and had done for a long time. He was street homeless. He slept on a park bench. He had diabetes. He had high blood pressure. He had kidney disease. He was actually having some trouble with his vision and a little bit of early dementia. And every time he'd come into the hospital, he'd get discharged with 30 medicines on his list, because every single condition he has decision support, and there are guidelines. And the hospital, actually, the EMR doesn't let you discharge someone who's had a heart attack in the past, at any point in the past, without having them on an ACE inhibitor and a statin and an aspirin. And so he would get this list of 30 meds, and then he would go and he'd come right back in. And at some point, I was his attending physician. I had my coterie of residents and medical students. And I said, somebody asked this gentleman what meds he could take and how many. And so we said, let's do an experiment. Let's talk to this man. Let's talk to this man who's struggling with alcohol use and mental health and diabetes and let's ask him what actually is feasible for his life. And what he said was, I can take 5 medicines, only 5. I can't take anything that makes me have to use the bathroom at night because I have no place to go. I cannot take anything that looks important or that might get me robbed or hurt. So that inhaler that you like, people use that to get high. I can't take that. So pick 5. I can only take medicines twice a day. I can't do anything more than that. And so I sent the team off to a room and I said, go pick 5. And they were up in arms. They were livid. This is not best practice. This is not clinical practice. Like, you're asking us to do something that is not the right thing to do. And I said, well, actually, how do we know what the right thing to do is? people like him are not included in any of the studies about what the best clinical practice is for somebody who's got all these conditions. People like him were not included in the studies about what actually improves life expectancy for somebody who has heart disease, who also has all these other issues. Like, we actually don't know, and we should know. We have certainly the data and the experience. Like, why do we not start to build decision support around these people with complex needs, understanding that there's a hierarchy. And for some people who are walking around the world with, a hemoglobin A1C that indicates their diabetes is way out of whack, the first most important intervention might be to get them housing if they don't have a place to sleep. And that might be okay. And that actually might be best clinical practice. We just don't know because we've never asked that question. We've never tailored that decision support. So building decision support and a learning cycle that allows us to iteratively learn what works and what doesn't for populations with complex needs. That was another huge thing. The other piece then was actually workflow tools for clinicians and non-clinicians who work together. Anyone who's worked in EMR, and I've worked in I can't even tell you how many, knows that they're designed to help us disaggregate people into organ systems or problems or chief complaints, and to build plans of action for each one of those so that we can bill for them. They're not designed for people to collaborate and to hold each other accountable to getting work done on behalf of and in partnership with members and patients. They're not designed for loop closure. You make the referral. Who knows how many of them actually get done? Who knows if the person actually sees the provider on the other side, if they go to the food pantry and actually get food. They're not tied to those types of outcomes. And so we needed to build a tool that was actually tied to workflow, that was realistic for the populations that we were serving, that helped us build a trustworthy system so that when a person interacts with us, we know what's going on with them, not just on what is going on with your kidneys, but what's going on with you as a human in all of the domains of your life that are important to your health. And that we have a really clear way of assigning tasks to each other and working collaboratively so that we can keep the ball rolling on the things we've committed to doing for our members. And then finally, we needed tools, technology tools, to help us engage digitally with a population that has not been the primary focus of a lot of health tech. And so when you go to the App Store, you go to Google Play or whatever, there's tens of thousands of apps, healthcare related apps, wellness related apps. Very few of them were designed with the interests of somebody who maybe doesn't have a smartphone, maybe doesn't have a lot of data, maybe can't remember or keep track of this two-factor authentication they need to do every time they log in, but a person who could use technology if it was built for them, and could engage virtually and digitally if it was built for them. And we need to really understand that and build tools for them.
Toyin, you've had the great blessing of being able to combine your career with a mission. And a lot of people, or a purpose, I should say, a lot of people are struggling to find that. They're struggling to find their purpose. What advice would you have for our audience out there around creating a career that also is in line with your purpose?
I think the first thing is, I can't say this loudly enough at this moment in time. There's no shortage of purpose in our society, of need for people who are engaged and thoughtful and community oriented to do things that impact others besides themselves. We need that so much right now. And the opportunities for that and the needs of people who are less fortunate in our society and our community are they're abundant and they're evident everywhere. And we see it in, this increasing sort of recognition and data around health disparities. We see it in our communities. We see it in the way that, even the COVID-19 pandemic has differentially impacted certain communities versus others. It's everywhere. And so the first thing you have to do is to listen to and figure out how to reckon with your privilege relative to others, and create a personal thesis about what it looks like to do social justice work in every element of your life, if that is where you're so inclined. But I think we have to be, because we have not created a social policy framework that does it for us, that takes our tax dollars and builds that infrastructure and builds that safety net for us. So we have to deliberately choose to lean into that purpose. And it is possible to live a life and to have a career and be successful and not do that, and not have impact on others beyond yourself. I think that's the first thing. I think the second thing, and I say this a lot to medical students, but I think it applies to everyone, is also figure out what you're good at and like hone your craft. And it doesn't have to be at the sort of front lines. It doesn't have to be, you know, as a doctor or as a nurse or as a community health partner or as an outreach specialist. It can be, I'm really good at finance, and I'm really good at managing spreadsheets and data and information. I'm really good at computer software programming, and like whatever it is, find the thing that sparks your curiosity and your craft and get really, really good at it, because we need excellent skills and talents applied to these really hard problems. And the folks we're seeking to serve, when we do social justice oriented work, when we do purpose oriented work, they deserve the best of our skills and our abilities. And then I think the next thing is then ask yourself how you reconcile those things in every step of the way. I think that there's a real acceptance for the idea that you take care of yourself and you build your career, and then when you're done, you can then give back. And the idea that you can't do both at the same time, I don't believe in that dichotomy. I don't believe that that's a trade-off. And so would really urge people to look at opportunities presented to them and to ask whether or not they are aligned with their purpose, whether they are aligned with impact on others, on the society, on building a world that is better than we found it. And then figure out how to apply their incredible skills and talents to doing that work.
Very well said. Last question, Toyin. We like to learn from thought leaders like yourself. What books have inspired you or are you currently reading? And what's on your playlist from a podcast perspective?
Ooh. So I have been reading actually Octavia Butler at the moment. So I'm reading, interestingly, a book about, a series of books about what it looks like to build a movement around social change, and what it looks like to grab people around you in a time of real distress and real social upheaval, and create a unifying purpose and drive together collectively towards building communities that are self-sustaining and supportive and values-oriented. And so it is an interesting book for the time, set of books for the time. I'm reading Parable of the Sower, rereading Parable of the Sower and Parable of the Talents by Octavia Butler, that really has been helpful, sobering and helpful to me as I think about what leadership looks like at a time like this. And podcast-wise, I listen to The Daily almost every day on my morning run, just to kind of get updated on the news. And I think that they're insightful and really thoughtful. I have really enjoyed listening to Andy Slavitt's podcast as we think about kind of following and really staying up to date with what's going on with the COVID-19 pandemic. And then I also very much enjoy Brene Brown's podcast, which I can't remember the name of it right now, but I love her insights as I think about how to navigate relationships and people, and so find that really insightful as well.
Well, thanks for sharing that. Really appreciate it. And I very much appreciate you being here and sharing your background and some of the wonderful work that you're doing at Cityblock.
Thank you so much. Thanks for having me.
Well, we're glad to have you. And for our listeners, that's it for another episode of Be Time. Thanks for being here.